sometimes see cystoid macular edema as a reaction to CNV. The retina starts to have cystoid spaces in it, okay, and in some cases subretinal lipid, as we saw here. Sometimes the CNV is masked by an elevation of the pigment epithelium. Remember, we told you that the CNV could be either growth through the Bruch's membrane, under the retina, or under the pigment epithelium. And if the pigment epithelium is really elevated because there's a lot of exudation, from the CNV, then you may have a pigment epithelial detachment. That is also a sign of CNV. In some cases, it's a little late. You have already some fibrosis happening, and you can get cases where subretinal fibrosis, and you know that this is subretinal fibrosis because the fibrosis is under the retina, and you can see the retinal vessels going on top of it, and here is the blood under the retina. Now, how do you distinguish clinically subretinal blood from intraretinal blood? Who can tell me? I need one volunteer, even a fellow. Dr. Marek, intraretinal blood would have what shape? Okay, depends on the layer. Good. So? Okay. Okay, so flame-shaped is when? Okay, so you have these streaks, flame-shaped, if it's in the nerve fiber layer, and you have these blotches, okay, dot and blot hemorrhages, if it's in the deep retinal layer. And if it's subretinal, it will have a blotchy appearance, okay? It's gonna be kind of geographic. Just imagine that you have a flake of water, a little bit of water, and you bring in a tea glass or a glass, okay? It's transparent, and you smudge the water with a glass. What happens? The water is gonna spread, and it's gonna have this geographic polypodal appearance, okay? So this is what subretinal blood looks like. So why am I saying this? Because if you see subretinal blood, your antennas are gonna go immediately. Zzz. This is CNV until proven otherwise. What does that mean? CNV until proven otherwise? What does it mean in practical terms? What? Injection. Are you kidding me? What does it mean? CNV until proven otherwise. You have subretinal blood, you are going to say, oh my God, I see subretinal blood. What does that mean? I have to think of CNV until proven otherwise. What do I do? Okay, besides the OCT? Okay, when are you going to do it? Next week? Same day, okay? So basically, it's an emergency, all right? It's urgent. Maybe not an emergency, but definitely urgent. All right, so, but not all subretinal blood is CNV, and this list you need to know, okay? So you can also have subretinal blood if you have macroaneurysms of the retinal arteries, or if you have a crack in myopia that cracks, that lets out a little bit of blood, or choroidal ruptures after trauma. You can even have subretinal blood after a posterior vitreous detachment. Now, generally, we think of PVD as something pulling on the retina, causing a retina to break, and then basically that blood goes into the vitreous and you see all these floaters, right? But if the hemorrhage is thick enough in the retina, it can go under the retina, right? So you can also have subretinal blood in the case of PVD, and of course in any choroidal tumor you can have subretinal blood. So, but just remember that any vascular disease, retinal vascular disease, in which intraretinal hemorrhage has dissected under the retina, of course, can give you subretinal bleeding, all right? Now, what is the differential diagnosis of subretinal fluid? Is when you have, the classic central serous chorioretinopathy, any inflammatory condition of the RPE in the choroid, such as in Harada's disease or posterior scleritis, where there's inflammation and exudation of fluid towards the suprachoroidal space. If you have uveal effusion by the same mechanisms, but again, also tumors of the choroid that exude, such as hemangiomas, okay, but also melanomas and nevi, and to a certain degree, metastasis and osteomas. Now, if you have a CNV that you suspect, then you need to do prompt investigation, FA, fluorescein angiography, and OCT. The importance of fluorescein angiography is that it's going to confirm the diagnosis. It's going to identify the type of membrane, the type of CNV, whether it's classic or occult, its location with regards to the center of the fovea, its size, and it's going to permit you to select the appropriate treatment, but you need to have good FA with early phases, okay, on the eye in question, with mid and late stereoscopic views to see the leakage and to see the elevation. You can also use OCT, which To date, it doesn't really replace, FA, but it will give you certainly a lot of information, okay? It will guide you towards, yes, this being CNV versus not. So it gives you additional info, but it's very, very useful in follow-up. So if you're going to start injecting people, then OCT is definitely the way to go with follow-up. Now, FA confirms the diagnosis. Here you see a grayish ring of CNV. And if you look at the fluorescein angiography, you're seeing basically a hyperfluorescent patch of that is right in the center with surrounding blocked fluorescence, which could be blood or it could be elevated RPE also, because RPE has a lot of melanin. So when you have a thick RPE around the CNV that's trying to suffocate the CNV, you will have this ring, what we call elevated blocked fluorescence. And you have these RPE changes. So this is FA confirms the diagnosis. It identifies whether it's classic, it's occult, it's polypoidal, or it's a retinal angiomatous proliferation. These are the 4 types of CNV. Now, and type 1 CNV is what we call an occult CNV, is the one the vessels grow under the retinal pigment epithelium and they stay under the RPE. So they are growing between the choriocapillaris Brooks membrane and the RPE that stays in here, okay? This is type 1. Okay, it has not progressed yet to type 2 to go further towards the retina. So a type 2, which is what we call a classic membrane, is when the membrane here, when the vessels have crossed the RPE and have started to grow under the retina and are exuding fluid under the retina. You have a type, the PCV, which is the polypoidal vasculopathy, it is a variant of type 1. Okay, it is limited to the sub-RPE space. So the vessels here, these polyps, these saccular dilations of the choriocapillaris are going to grow under the RPE and they're going to stay under the RPE, okay? And the RAP, which is the retinal angiomatous proliferation, it's a very distinct type of choroidal neovascularization. What happens here is that you start to have a retinal neovascularization that grows downwards towards the choroid, and at the same time you have basically vessels growing from the choroid towards the retina and meeting together. So this is a double neovascularization, and it's harder to treat. Now, let's look how a classic CNV looks like. Classic CNV on a fluorescein angiography will show you early hyperfluorescence, can be of any size, it can be small or big. This is a big one. Early hyperfluorescence, very, very intensely hyperfluorescent, that leaks towards the end. Leaking, meaning it has a fuzzy edge and really super hyperfluorescence towards the end. Okay, this is leakage. It usually has well-demarcated boundaries. Classic membrane, you can trace it with a pencil. This here is under the fovea, so it's subfoveal. This here is away from the fovea, but notice that this membrane, this is the fovea. Notice that this membrane is away from the fovea, but you can really trace it in the early phases on the fluorescein angiography. And towards the end, everything is dark. All right, it's dark because the fluorescein is going away from the eye. The vessels are hypofluorescent compared to what they would be in the beginning, okay, compared to here, right? These are darker. Everything is darker because the fluorescein is going out. But where the vessels are, where the neovessels are, that fluorescein continues to leak and leak and leak, and therefore you have this intense hyperfluorescent with obscuration of the boundaries, okay? So is that clear? Should be clear enough. This is the easiest, all right? Classic membrane, all right? Now, how does a classic membrane look on OCT? Where did we say a classic membrane is? A classic membrane is what? Type 1 or type 2? Type 2. It's, even if you don't know, it's written, okay? So, type 2. Type 2 membrane is a classic membrane. That means it has gone further than the RPE under the retina. So, let's go back and look at the OCT. What is this layer here? RPE. And this is the choroid, right? With the vessels. Correct? And this is the sclera, that is avascular, correct? So here is the RPE, and this area here would be the what? What layer is this? The photoreceptor layer, the ellipsoid zone, okay? It's kind of thick here, but because you have a lot of leakage. So you have the photoreceptor zone right there, and that little tiny, tiny hairline is the, yes, music to my ear. Okay, so basically you have something growing through the RPE under the neurosensory retina. Yes? So that is a classic membrane. This is a pretty clear example I just realized that I have put all these things here and I'm asking you. Okay, never mind. All right. I didn't even notice that I put the annotations. That's good. Good for you. All right. So here's again another one, an example of a CNV in which you have the grayish membrane, you have the RPE right there, and you've got the thickening above the RPE, and you generally you have leakage either under the retina or inside the retina. Often the retina is incapable of getting its fluid out because the RPE is sick, so you get these cystoid changes in there. And on the fluorescein, beautiful boundaries that are well demarcated, early hyperfluorescence with well demarcated boundaries, and then late hyperfluorescence with obscurations of the boundaries by the leakage. And notice what's happening here. What is that? What are these? What is this? Yeah? What? Cystoid what? Huh? Cystoid? Yeah, you have cystoid macular edema in addition. So you can tell that you can have cystoid edema in addition to the subretinal leakage, okay? So there's not just subretinal fluid, but there's also intraretinal fluid. So yeah, this is the pooling of the fluid in the cystoid spaces in the outer plexiform layer. All right, here's another example of a classic CNV between the retina and the RPE. Again, this would be what? The RPE, the most hyperreflective zone, and then it starts to elevate. What is elevating is actually this ellipsoid zone. It's elevated here, and here you have the membrane and some cystoid changes as well. All right, so we got that. Now, the other type of membrane is an occult CNV, which can be divided, we used to divide it based on the fluorescein features into two types. Either what we call a fibrovascular PED, meaning you have in the beginning an area where stippled hyperfluorescence. So it's not really normal fluorescence. There's a little bit of hyperfluorescence, but kind of grainy, irregular. You cannot always define where it is. But at the end, when you go like within 1 to 2 minutes in the angiogram, you start to notice that there is much more hyperfluorescence in this area that corresponds to the area of stippled hyperfluorescence. This means that you have a membrane growing under the RPE. The RPE is masking the fluorescence, so you're not seeing it as clearly as if it's through the RPE and just under the retina, but eventually the leakage inside this pigment epithelial detachment from the vessels is going to manifest itself with increased hyperfluorescence, okay? So this part is occult. How about this part? How about this part? Is this occult? Please raise your voice. It doesn't matter if you make a mistake. This part, is this classic or occult? Classic. You're right. You're right. It is classic. It is classic because you can really very easily demarcate it from the beginning. It's very clearly demarcated, right? And then here it becomes a little fuzzier and bigger in size because you have fuzzy edges and very intensely hyperfluorescent. So this is a classic part, and this is the occult part. This is the occult part. So the membrane is not just here. The membrane is this entire thing. Part of it is classic under the retina. Part of it is still under the RPE. Got it? Okay, now you can have another type based on the fluorescein angiography, another type of occult CNV, what we used to call late leakage of undetermined source. يعني واضح من الاسم, you don't know where it's coming from. You basically have stippled hyperfluorescence, speckled hyperfluorescence. You really cannot trace it with a pencil. You don't know where it starts and where it ends. And then at the end, you do have a lot of hyperfluorescence and leakage and fuzzy edges. Okay, so the source of the leakage here cannot be determined. You can argue with me that this could probably be a type of classic membrane, but it's a little bit hidden right there. But all this is actually late leakage of undetermined source. Okay, now, here's an example of a fibrovascular PED, a big one, occult membrane. Notice that you really cannot tell for sure where the membrane is, but you know for sure that there's a membrane because there is hyperfluorescent, intense hyperfluorescence in those areas, okay? And if you look at the CNV on OCT, this occult membrane, this is a little different now. Notice that now you're seeing the RPE, you're seeing the Brooks membrane very nicely, this hairline structure. Okay, and notice that if you follow the retinal pigment epithelium, it's pretty regular here, and then it starts to corrugate, and then it starts to elevate off the RP, of the Brooks membrane, elevated, 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 oop, whoops, and down. Okay, and everything here is really multi-layered under the pigment epithelium, between the pigment epithelium and the RP and the Brooks membrane. So you see the difference? Yes, is that clear? And of course here you have subretinal fluid and you have shaggy photoreceptors because the RPE is unable to eat up all that. Now, this is another case of occult CNV. Here is the okay, for this patient has had laser before, so don't get fooled by this one. This patient here has, obviously in the late phases of the angiogram, has a lot of leakage. Okay, you can see on the picture that there is leakage indeed of subretinal lipid, and if you look at this cut here, you are really clearly seeing the sub-RPE component of the membrane. Here's the choroid, here is the Brooks membrane. Okay, it's kind of masked before the segmentation line. Here's the RPE, and then the RPE itself, it elevates. Okay, it is elevated right there. All right, right there, elevated. Here is elevated again. In this case, we call this just a PED, the drusenoid PED. Here's clear subretinal fluid. And here, between the RPE and this area here, this is what we call SHREM, okay, which is subretinal hyperreflective material, all right? Because sometimes with chronicity, you get the subretinal hyperreflective material. But what I need you to notice is that there is stuff here. This is not clear. The retinal pigment epithelial is elevated, and the stuff down under it is not clear, yes? Because a clear PED, a serous PED in central serous chorioretinopathy would be clear, would be black. This is, there's something there. So it's either fibrous or a membrane. And since you have subretinal fluid, since you have a little bit of SHREM, you have cystoid changes, you know that this is an ongoing activity of the CNV. Okay, now, in terms of size and in terms of speaking the correct words, when we say CNV, generally, we just say choroidal neovascular lesion. But when we say the choroidal neovascular lesion, we mean not just the component that leaks. We also include, in the determination of size, the blood that surrounds it, the RPE that surrounds it, and in some cases, the PED that surrounds it, okay, that overlies it. Okay? So, what can obscure the boundaries of the CNV? Here, for instance, you have subretinal blood. You notice that this is subretinal blood. This is no way intraretinal blood, صح? We talked about that glass that you squash the water with, okay? So basically here you have subretinal blood all over, subretinal lipid, you know, because the vessels are going on top of it. The vessels are going on top of this lesion. And this lesion, you can see in the fluorescein angiogram that you have hyperfluorescence. So you know that there is a CNV there, right? But can you really tell me where it stops? Not really. Why? Because you have the subretinal blood that masks it. It covers it, okay? It blocks it. So you don't really see it. So in case where you have this, and in the old days, we used to consider that the CNV went all the way to the blood, just to be on the safe side, that when we were treating the entire lesion, okay? So this is what we call the CNV component. That means the vessels, the choroidal neovessels that leak, all right? But the CNV lesion, the lesion itself is made of the component, whether it's classic or occult or a combination. It's also made of the blood that surrounds it, and it's also made in sometimes of, you know, elevated blood fluorescence, which corresponds to hyperplastic RPE. This hyperplastic RPE right there, meaning this RPE is trying to cover the CNV and trying to suffocate it so that it doesn't grow any further. And because the RPE, here it looks white, yes, but on the fluorescein angiography, this RPE looks black like we saw earlier. Okay, when I showed you. I don't know if you can go back. Maybe I can see it. Maybe it's here, just to show you what it is. Here, for instance, this part here. This part is probably more likely, it could be blood, I'm not sure, but this is how it would look like if you had an elevated RPE. So the features that obscure the boundaries are also hyperplastic RPE, and the features that obscure the boundaries are also pigment epithelial detachments, which can be serous in this case, not fibrovascular. You have so much fluid under the retina that it obscures the boundaries of a CNV. So this means that a CNV that is classic is well demarcated, always well demarcated, However, sometimes it is obscured. The boundaries are obscured. This is different from an occult membrane, which is usually poorly demarcated, okay? So a serous PED can sometimes cover the CNV, and in general, where where the CNV is, you often have a little notch here. So, and a serous PED would look really, hyperfluorescent with very, very clear and well demarcated boundaries. All right, so we talked about this. So what are the CNV definitions that we need to know? The lesion itself, which is composed of CNV, classic or occult, thick blood, elevated blood fluorescence, and serous PED. And the CNV lesion is the entirety of this, okay? Now, why is this important? Well, it used to be important, and it still is relatively important in terms of prognosis, okay? Classic membranes have worse prognosis than occult membranes. هذه واحدة, okay? But in older days, where we used to treat with photodynamic therapy, we used to base our treatment indications based on the components of the lesion. All right? Meaning, we used to offer PDT to lesions that were predominantly classic. What does it mean, predominantly classic? That means if you have the lesion meaning the CNV component, the blood, the elevated blood fluorescence, the PED, this entire thing, the surface of this entire thing, if the CNV component was more than 50% or more, then you have a predominantly classic CNV. Here is the example, predominantly classic. This is blood. This is an occult CNV in this area. And here is the classic membrane right there. Here it is. And this area is much bigger than the entire thing, much bigger than half of the entire surface. So this is what we call a predominantly classic membrane. Here it is again. This is a predominantly classic membrane. Here we have the classic membrane. Here we have the occult membrane. Okay? In the late phases, everything leaks. So we go back and we look here and we see where's the classic, here. Let's outline its boundaries. And then we figure out that this, the machine makes the calculation for us, and we know that this is more than half of this. So this is a predominantly classic membrane. You guys don't need to do this anymore, but this is important for you because if you see this in the literature, you need to know what the predominantly classic membrane is. A minimally classic membrane is a membrane in which the entire lesion is measured and the classic component is smaller than 50% of the entire lesion. The opposite, right? Here it is. Where would the classic be? Tell me. Here, where would the classic be? Where's the classic component? On this side, yes, it's right there. This is the classic component. But this is occult. Stippled hyperfluorescence at the beginning and lots of leakage at the end, right? So this is, correct. Sorry about that. All right. So here is the classic component, and this is the entire lesion. And obviously, 2.57 is less than half of 1031. You can also have occult with no classic. And in those cases, you cannot determine what the classic is. Okay, here is an example of occult without classic. Although I would think that this is probably a tiny classic right there. Anyway, so now, never mind. Okay, now we're talking about the third type of CNV, which is the retinal angiomatous proliferation, the RAP, where I showed you that there is intraretinal neovascularization that connects to a subretinal neovascularization. What you see on a fluorescein angiography is what we call an early hot spot, okay, retinal, okay, and you see it in the retina when you do an exam, all right? And then basically when you do the OCT, you're going to see a focal tiny PED, okay, and intraretinal cystoid spaces. You don't necessarily see a very, very big membrane, but these are very active membranes. Here is, again, a little focal hotspot right there, okay? And sometimes the earliest sign of a RAP is a tiny intraretinal hemorrhage. Intraretinal. So a tiny intraretinal hemorrhage, and then with time, it increases in size right there, okay? And you have a PED with cystoid spaces. This is pretty pathognomonic. Polypoidal CNVs are, remember I told you those saccular dilations in the choroidal vessels that remain under the pigment epithelium. So, and this can look like a classic CNV clinically, or it can look like a PED. It sometimes can look like a CSCR, right, with a lot of fluid. and with some intra or subretinal, with some subretinal hemorrhages. If you do a fluorescein angiography, you don't always see the polyps, okay? But if you do an ICG, an indocyanine green angiography, which is very good for visualizing the choroidal vessels, but not the retinal vessels, then you can see these branching networks, okay? And with the branching networks, you can sometimes see these saccular dilations, right? Very nicely here. Often the polypoidal lesions tend to have a lot of blood, and then they tend to have a lot of lipids. So when you see a CNV with a lot of lipid, think of polypoidal, all right? Now, never mind. So what is nice about polypoidal is that can really be very, very nicely identified on a fluorescein, on the OCT, if you go through the cuts one by one. Here is an ICG, okay? You know that this is an ICG because this optic nerve is dark, right? And the vessels are white, so it's not an autofluorescence, right? And then here in the ICG, you're seeing these saccular dilations. And if you do a cut through these saccular dilations, which are the polyps, you're going to see an elevated pigment epithelium, actually a double elevated pigment epithelium, and a little polyp right under the surface of the PED. The polyps are under the belly of the RPE, all right? So it's between the Brooks membrane and the RPE. It's at the undersurface of the pigment epithelium. If you go away from the saccular dilations, you don't see this anymore. We may have better, yeah, this is nicer. Okay, here is a typical polypoidal lesion in which you have subretinal blood, subretinal exudation. You do then ICG, you notice these little whitish, hyperfluorescent round circles, okay? You do a fluorescein an OCT right through that, and you see the pigment epithelium is elevated, okay? This is Brooks membrane, and what do you see here? What are these? Polyps. You see them? See those round balls right there? So these are polyps, okay? And this is the elevated pigment epithelium, and this is some of the exudation with a Schrem, and here you have some subretinal and intraretinal fluid. Okay, here's another case that is taken by a report, from our patients, by Dr. Ghazi and collaborators. So these are KKESH patients. Again, you do an ICG through the polyps, and you can clearly see this what we call the M-shaped or the W-shaped irregular notched PED. And often where the notch is, you have a polyp right there. You have a polyp right at the undersurface of the RPE. What is this line, people? What is this line? Brooks membrane. Absolutely. Okay, so they are between Brooks membrane and the RPE, usually stuck to the undersurface of the RPE. Is that clear so far? Okay, here's a wow example in which you can also see the branching network. I think right there, that would be the branching network right there. Okay. And again, polyps. If you look carefully, once you recognize it and once you start looking for them, you will see them. You only see what you look for, huh? And you only look for what you know. So you need to know first, then look for, and then you'll see it. So basically, the FA is going to show you the location of the CNV, extrafoveal, juxtafoveal, and subfoveal. So by definition, so the definition مش من عنا, okay, we just say extrafoveal, juxtafoveal as we wish. No, it has a specific definition. When we say extrafoveal, it's a CNV in which the boundaries, the limits, the edge of the CNV is more than 200 microns from the center of the FAZ. Okay? In clinically significant macular edema, we use the distances from the edge of the FAZ. Right? Okay. In CNV, we use the foveola, the umbel, okay, as the location, okay, of reference. So anything that is beyond 200 microns, it's extrafoveal. And 200 microns is really, really not, small, okay? 200 microns, I mean, a big vein, retinal vein, close to the optic nerve. It has what diameter? Sorry? 125, تقريبا. Okay? So 200 is like, like two veins width. It's not far. That's already extrafoveal, all right? So extrafoveal, 200 to 2,500. Juxtafoveal, okay, for the purpose of doing laser, and not for the purpose of doing PDT, but for the purpose of doing laser, because 20 years ago when I started, we didn't have any PDT, we didn't have injections. You know, people were doomed to lose their vision because we did laser. We lasered these cases because if we didn't, they would grow even more. So we had to do laser, but it was very destructive. So alhamdulillah that we have anti-VEGF, okay? Anyway, juxtafoveal is anything between 1 micron, okay? Good, if you can detect that, 1 micron to 199 microns from the center of the FAZ, and subfoveal is when the lesion extends under the center of the FAZ. So if you have the edge of the CNV lesion under the center of the FAZ, what is that? Subfoveal. And if you have a lesion with a lot of blood around it, but the blood extends under the under the center, what is it? Subfoveal. You got that? You see why I was telling you about the blood and all that? Because that's part of the lesion. All right? Okay, so here is an extrafoveal. So you can see that it's not far, and a lot of people say, oh, this is juxtafoveal. No, ma'am. This is extrafoveal, okay? And this would be a subfoveal CNV. All right? So, never mind, you don't need this. Okay, so once the diagnosis of CNV is confirmed, so what do you need to do? You need to see why is there a CNV? So you need to see the associated condition. What did we say the biggest condition was? Age-related macular degeneration, which is, change in the macula and in the retina as the eye matures, and it's a leading cause of blindness in people over 50 years old. There are some risk factors that are non-modifiable. The age, you cannot change your age, okay, I wish, but and genetic factors as well, but modifiable ones that help, make AMD come in faster. If you have a high blood mass index, if you smoke, or if you have low level of antioxidants. And classically, we classify AMD into early and late. Early being have an eye that has soft drusen and some RPE changes. And late AMD is when you start to have the complications of this, either going into geographic atrophy, dryness, okay, a dry AMD, or in a wet fashion if you start having neovessels, any type of neovessels, okay? So the non-neovascular AMD is still the biggest, most people have non-neovascular AMD. Those who have AMD, they have non-neovascular AMD. Mostly they are drusen, okay, and RPE changes, but also geographic atrophy. And then the neovascular AMD, about 10% of those go into neovascularization. They have CNV, the pigment epithelial detachments that go with it, and the disciform scarring. Now, drusen are the hallmarks of AMD. They are sub-RPE deposits. They are predominantly in the macula, but they can also be peripheral. They can be small and sharp, and in those cases, they're not really high risk. The ones that are high risk are the large ones, okay? The large drusen, the confluent drusen, and they are the bigger their size, the more confluent, and the bigger their number is, then the higher they are. So drusen are these little tiny pigment epithelial detachments, okay? These are the drusen are basically deposits of stuff, of junk, behind the RPE. And the deposit can be either under the basal membrane of the RPE, or it can be sometimes under the Brooks membrane, all right? But that's where it is. So we talked about that. So drusen, when they atrophy, they can go into what we call geographic atrophy, and this causes a lot of visual loss. No CNV, but there's atrophy of the photoreceptors, atrophy of the RPE in the center. So of course, people cannot see very, very well. So you have these large areas that sometimes start in many places, and then they become confluent, okay? And if you do an OCT, you definitely know this by now, is that you have a loss of the RPE in the photoreceptor layer, the ellipsoid zone, the external limiting membrane, and you have inverse shadowing. So here it is on an autofluorescence, an area of geographic atrophy. You notice that clinically sometimes it's difficult to see the boundaries, but if you use autofluorescence, you can really follow the progression of the geographic atrophy very, very well, because you can clearly delineate it. This is an area where there's absolutely loss of RPE and photoreceptors. The area of hyperautofluorescence surrounding it is the area where the RPE is still active but pretty sick, because it shouldn't be hyperfluorescent. Okay, CNV happens in about 10% of patients, okay, of AMD. As we said, it could be occult or a classic, and it has a poor natural history, as you can see here, all right, because it goes into disciform scarring. This is the same eye, huh? This is one of my patients. His mother had AMD, his siblings had AMD, and he also has AMD. This is how it started. You can see the lots of drusen on the fluorescein angiography, and even clinically, this is how it started. And then a few years later, despite treatment, he ends up with a huge scar and a progression. This is a never-ending saga. Okay, for people who are hooked to television sitcoms, this is a television sitcom. CNV is for life. Okay, there is continuous growth, scarring, scar remodeling, growth, scarring, scar remodeling. It's for life. This is why anti-VEGF treatment is a huge burden for them, for the patients, but also for the health system. So the natural history of CNV is poor, particularly in AMD. They grow and they will not cease to grow. If you stop treating them in the beginning, a few months, you can say, oh, that looks stable. Oh, you'd be surprised. A year later, oof, it's much bigger. Okay, so generally a poor history. You don't need this. This is the classification of AMD according to the age-related eye disease study, we call this AREDS. This is going to be in your handout, so you don't need to worry about that. Okay, the other cause of CNV is degenerative myopia. Okay, and degenerative myopia also has characteristic features that you need to know. What is degenerative myopia? We consider that it's more than 6 diopters, although now more and more studies are mentioning 8 diopters or more of refractive error, in which the axial length is more than 26 millimeter, and in which you have progressive choroidal degeneration of the posterior pole. What are the features? Myopic conus, okay, this which is here, the staphyloma, and a lot of people confuse this peripapillary atrophy with staphyloma. What is a staphyloma? What's a staphyloma? This is not a staphyloma. This is a chorioretinal peripapillary crescentic atrophy, or what we call the myopic conus. A staphyloma is the posterior bulging of the eye wall. Okay, so the eye wall, instead of being regular, it is going to be a little bit irregular. It has little bumps, okay? Bumps going out. Some bumps are nasal, some bumps are temporal, some bumps are macular, some bumps are inferior, and there's a classification for that. So those outside pouches, where the eye wall pouches a little bit backwards, and of course the retina follows, that's a staphyloma. And you can see a staphyloma very easily if you do an indirect ophthalmoscopy, because indirect ophthalmoscopy kind of maximizes your stereopsis. So everything that is bulging either forward or backward is going to be maximized. You can see it easier. Often people with myopia, they have these stretched retinas, stretched sclera, thin choroid and sclera, and therefore everything is stretched, and it's easy then to have atrophic areas that grow with time, and geographic areas that grow with time, geographic atrophies of the choroid and the outer retina. You can also have lacquer cracks, which are cracks in Brooks membrane. Okay, the eye stretches so much that the Brooks membrane just cracks, and when it cracks, it can bleed. And you can have these subretinal hemorrhages without CNV, and sometimes what we call Fuchs spot. Here's an example of a lacquer crack. Myopia, okay? You can see the vessels of the choroid really easily, okay? And this is a feature, this is the hallmark of myopia, a lacquer crack, which is linear or arcuate or stellate, thin or thick crack in the Brooks membrane. Okay, it's usually yellow or white. It can be multiple, and on a fluorescein, it shows early hyperfluorescence and generally no leak. And often this lacquer crack leads to CNV. You can often have a CNV that grows on top of the lacquer crack. You can have macular hemorrhages from the cracking, okay, from these lacquer cracks. You can get these, what we call the coin-shaped hemorrhages. So when you see a coin-shaped hemorrhage under the retina, it's a subretinal hemorrhage. What do? What is a subretinal hemorrhage? CNV until proven otherwise. So what are you going to do? Huh? Fluorescein, right? You're going to do a fluorescein angiography. Looking for what? Leakage. And if you see leakage, what is it? It's a CNV. And if you don't see leakage and you just see this masking because of the hemorrhage, it's a It's a hemorrhage, due to, the coin-shaped hemorrhage that people with myopia can get. Now, mind you, if the hemorrhage is large and if it's thick, it may mask a tiny CNV, but that's usually not the case, okay? Now, so there's a good prognosis for this. You just watch them. You don't do anything to them, okay? A Fuchs spot is this dark area that you will definitely see one day when you examine patients, myopes. It's a dark spot in the macula that signals that there was a presence of a previous CNV in which the RPE proliferated and kind of suffocated the CNV. Okay, that's a Fuchs spot. Okay, so CNV in high myopia happens in about 10% of cases of high myopia, and often the lesions are kind of gray and small. Okay, so sometimes they're hard to detect. The notosensitive retinal detachment is generally not big. They usually don't have subretinal exudates, and in general, the hemorrhage is very limited, okay? And here it is. For instance, you have a case of high myopia. You can see the conus, you can see the tessellated fundus, and here is the membrane with subretinal blood around it, all right? Here's another case of myopia. You can see the conus, okay? And the tessellated fundus, the little bit of an atrophy in this area. But when you do the fluorescein, you notice that you're seeing, what are these lines? What are these lines? Lacquer cracks, right? There are lacquer cracks. And in the lacquer cracks, this is pigment, okay? But right next to the pigment, you don't see much in the early phases, but if you go with the late phases on the angiogram, you're seeing hyperfluorescence with fuzzy margins, right? So definitely, what's in here? A CNV that grew on top of the lacquer crack. So what are you going to do? Inject. I love it. So standard. Okay. All right. So here it is. Again, that patient that I showed you earlier, the myope with a lacquer crack, you can practically not see much, but then when you do a fluorescein angiography, you see the stippled hyperfluorescence and a really, really neat, late hyperfluorescence with leakage. So you know that you have a membrane and you're going to do what you know how to do is best, which is inject. Okay, now, CNV and high myopia don't have as much of a bad prognosis as AMD, but I can tell you they often need more than just one injection, okay? So they need to be followed. Angioid streaks are also similar to lacquer cracks. That condition can also lead to CNV. Remember what I said in the beginning? Anything that affects the choriocapillaries, the Brooks membrane, and the RPE can lead to CNV. So this is one of them. Again, angiostreaks can be associated with pseudoxanthoma elasticum, Paget's disease, and sickle cell anemia and Ehlers-Danlos syndrome. And in general, in those cases, it's just like AMD. You guys need to follow those patients very, very closely, because you inject them and a month later they still leak and you still have to inject them. And if you miss their injections, the CNVs tend to grow wild. Here, the lacquer cracks the angiostreaks are radiating from around the optic nerve. Okay, now you can have inflammatory CNV, such as an ocular histoplasmosis syndrome, or following traumatic choroidal ruptures. Okay, here's a choroidal rupture. I don't think anybody would miss that. And on the choroidal rupture, there is an egress of a CNV. Here again, you have choroidal ruptures, several of them, okay, early on, and then later on you have CNV. So CNVs happen in choroidal ruptures usually within the first 2 or 3 years, generally first or 2 years after the choroidal rupture. That's when they're most active. That's the highest risk. And the longer the choroidal rupture is, the closer it is the fovea, the higher the risk that this patient would develop a CNV. So it's a good idea for if you have a patient with choroidal ruptures, now you cannot do anything, right? There's a trauma. Khalas, it's happened. You know what are you going to do? But what you're going to do is prevent the complication by explaining to the patient that he or she needs to monitor the vision with an Amstel grid and to report if there are any metamorphopsia, because that would be amenable to treatment. Some types of CNVs are idiopathic. You just look, you don't see the cause, but there is a CNV that's happening. CNVs can also happen next to the optic nerve, juxtapapillary ones. They have the same features as the classic CNV, but in general, you don't treat them unless the CNV is tending to grow, okay, under the fovea, or if the subretinal fluid from a CNV that is small, but the fluid is extending under the fovea, you treat that. And now the treatment is pretty standard. It's injection. Okay. Treatment, we're going to go quickly because it's getting late. There is no treatment at this point in time to prevent or to completely eradicate CNV, okay? So it's a serious eye condition that requires prompt treatment, serial follow-up, okay, and discipline in the follow-up from the patient and the physician, and the prognosis will depend on how early you got it and how well it was treated, and of course on the associated condition. AMD and angioid streaks have worse prognosis than, for instance, myopia and inflammatory membranes. And there are many, many, many treatments that have been tried along the years, but now we know that the easiest and the best treatment, and the safest treatment at this point is the anti-VEGF agents monthly, okay? But you need to know that photodynamic therapy was tried in the past and still continues to be applied in certain cases. Laser photoablation used to be the treatment of choice a long time ago. Forget that nowadays, except in very selected extrafoveal lesions. We also went in all the way to try to remove the CNV surgically. Not a good idea. They don't do well because you rip the RPE at the same time. Macular translocations, all that. I'm not going to go through a lot of that because that's not really relevant for you at this point, but just need to know about it, okay? You also need to know that in addition to all this treatment, you need to provide the patient with refraction, low vision aid, moral support as well, and counseling about the fellow eye. Okay. I may give you this in a handout because it's no longer really relevant for you, but in a long time ago, we used to do laser ablation, and you can still do it if it's really far from the center of the fovea, okay? Not as close as this, but this is one of those cases that I had treated a long time ago. So you could do a complete ablation of the CNV if it's extrafoveal, okay? You don't need, there's a lot of recurrence that comes with that. There is scotoma. The possibility that this recurs is always there, so it's not really the best treatment of choice. Now, the other treatment would be, for instance, to selectively occlude the CNV, either with anti-VEGF treatment, which is now the standard, or with photodynamic therapy. Okay, you can also cut the blood supply of the CNV. If you do an ICG and you know exactly where it's feeding from, you can do what we call the feeder vessel treatment. It is not as easy as it sounds. Remove it with submacular surgery, or move the fovea away from it, okay, and macular translocation. All these are really last resort treatment. We're going to concentrate essentially on the angiogenic treatment for CNV. This is now the treatment of choice, okay? You inhibit the VEGF, so you slow the proliferation, the angiogenesis, and you decrease the permeability, okay? What do we use? We used to use something called Macugen, okay, but it's not as effective as the newer molecules which block all isoform of VEGF, mostly Lucentis, Avastin, and Eylea, okay? And you all know that we do intravitreal injections. Now, Lucentis is a humanized murine antibody fragment, which inhibits all isoforms of VEGF. It penetrates the retinal layers really nicely, and you will need monthly injections, and you will get a visual improvement in about 40% of eyes in AMD, and stabilization in a large majority of patients, and it's relatively safe and tolerated, but it's expensive. Lots of trials were done before we ended up with those regimens. The most important trials in the Lucentis molecule are the Anchor, Marina, and the CAT. Those you need to know, okay? And I will give you a handout that shows, what were the patients who were involved, what was the randomization, and what were the studies. So the Anchor, in just a nutshell, Anchor study, it's a phase 3 trial that compared what was effective at the time. This is the first trial, which is verteporfin PDT versus the Lucentis, and it showed that monthly ranibizumab was effective and superior to PDT in maintaining or improving vision. In the PDT arm, patients continue to decrease vision. Patients in the Lucentis arm gained and stabilized. Okay, this was the first time that we actually saw a gain in vision. All right. Now, in the Marina design, it was also a phase 3 trial that compared ranibizumab to nothing, to no injection, in occult or minimally classic CNV. And why to nothing and why not to PDT? Because at the time, PDT was not recommended for minimally classic CNV. It was not very, statistically it didn't prove to be useful, so there was no recommendation to use PDT in minimally classic, just in predominantly classic. So they took these minimally classic, some got treatment, some got ranibizumab, and some got nothing at all. And of course, you can tell that the patients who got ranibizumab did much better visually. All right? So these treatments actually changed the standard of care of CNV. Now there are other studies, the PEER study, in which they used 3 monthly injections, okay? And then every 3 months. 3 monthly, and then every 3 months, once. And they found that with this regimen, that the vision was better than sham, but not as good as monthly treatment. So monthly treatment is the way to go, okay? With the Sailor and Sustain study, is what they did is they used 3 monthly injections, okay? And then they kind of did a PRN, not every 3 months, every month, but PRN, وقت اللزوم, okay? And they find that the gains of vision decreased over time. All right, and in the Excite study, after 3 monthly injections, the monthly treatment provided the highest visual gain compared to quarterly treatment. Basically, the most important one is probably the Horizon study, is that after 2 years of monthly ranibizumab, PRN could not prevent ongoing declines in vision, and less frequent follow-up led to fewer injections and loss of initial visual gains. So injections were well tolerated, but in general, people who did not have the monthly injection got worse over time. You all know about Avastin, and this is going to be in your handout. So this is still off-label. This is not FDA approved for intravitreal injections, but everybody does it, and it's just as good. And how do we know it's just as good? By this phenomenal trial that we call the CAT trial. Okay, it's a single masked, multi-center, randomized, active treatment controlled, non-inferiority study with ability to test for superiority. وش معناها؟ معناها they took people with that had CNV. Half of them were 5 minutes. Thank you. Half of them were treated with ranibizumab, and half of them with Avastin. Half of the people with ranibizumab got it monthly, and half of them got it 3, then PRN. And with the Avastin, they did exactly the same thing, half monthly and half with PRN. And basically they said, is there any difference? And actually, these are conclusions that are important for you to know, is that the bevacizumab and ranibizumab have equivalent effects on vision when given according to the same schedule. So PRN, Lucentis, PRN, Avastin, تقريبا نفس الشيء. The visual improvements, however, are greatest with monthly injections. And the monthly injections of ranibizumab had the best, reductions in fluid. And the monthly evaluation with PRN ranibizumab had the same visual outcomes as monthly. And that the rigorous PRN regimen does not reduce the management burden. So even with PRN, these people were still coming in every month for follow-up, okay? So there is really no reduction in burden, okay? And the systemic side effects were low. The Eylea is the latest kid on the block so far that's approved. The nice thing about the Eylea is that it can stay in for a longer period of time. The studies involving Eylea are called the VIEW studies, VIEW 1, okay? And VIEW 2, based whether they were done in the States or in Europe. And basically what they did is they gave 3 monthly injections followed by every 8 weeks, so almost every 2 months. And the results were just as good as with monthly injections with ranibizumab, maybe even a little bit better. These are the complications and the risks for anti-VEGF that you need to know. Hypertension, people can get hypertension immediately after the injection. You need to be careful with that. Some people you will notice in your practice are going to complain of headache after the injection. So that could be a hypertensive spike, besides getting high IOP, temporary. Thromboembolic events, myocardial infarctions, cerebral vascular accidents, and proteinuria. And of course, there are the injection-related, which is high IOP, retinal atrophy, and endophthalmitis. Okay, so I'm not going to go through this. Photodynamic therapy, we do this in selected cases only, because I know Dr. Abasar is waiting. We basically inject a dye called vortiporphin that reacts with a specific light. And this light is after an infusion takes place, IV for 10 minutes. And then 5 minutes after the end of the infusion, you basically put a specific light with a specific machine on the lesion after you have determined its size. Okay, so first of all, determine the size, like we talked about at the beginning of the lecture, and then you do a PDT that is the same size or slightly bigger, 1,000 microns bigger than the greatest lesion diameter, and this will occlude the CNV temporarily, okay, for 3 months, and then you need to repeat the treatment. Now, what happens, this is not less expensive, and it causes choroidal atrophy, so it does not always cause a lot of increase of vision. So right now, in a summary, in a nutshell, it's an adjunctive treatment. You can use it with intravitreal steroids. You can use it in addition to anti-VEGF. Particularly, where is it the most useful when you use PDT in the context of CNV is when you have polypoidal CNV. Okay, they respond nicely with a combination of PDT and anti-VEGF and in RAP lesions. Feeder vessel treatment, I'm not going to go with. Submacular surgery, you don't need to know it. And complications of all surgeries, as you know. So this is it, basically, people. Okay, the rest is not. The rest is going to be in your handout. Okay, the AREDS results and the trial results. Okay, I think we're out of time, so I have to quit. If you have questions, I'll be outside. Thank you very much. I don't know how to do this. How do you do this? And show. How do you do this? Ah.
السلام عليكم. This one.
الليزر بوينت موجود اوريدي. هذا الاحمر هنا. ايوه
ممتاز.
واليمين ويسار يمين ويسار.
وهنا ده ممكن نقشر بيها. نبتدي ولا لسه شويه؟
Assalamu alaikum. It gives me a great pleasure to present for you Professor Ahmed Al-Basrat. His talk today will be about a new molecule, osteoprotein. He already published about osteoprotein in 2 papers, one of them in IOBS. The title of today's lecture is Osteoprotein is a new regulator of inflammation and angiogenesis in proliferative diabetic retinopathy.
شكرا دكتور مروان. As you know, in our laboratory we are always doing screening for new molecules, hoping to discover new regulators involved in the pathogenesis of diabetic retinopathy, particularly proliferative diabetic retinopathy. The reason for that is to identify new biomarkers of angiogenesis or inflammation or fibrosis that can be used in the future as a novel target for treatment. During this process of screening, we identified a molecule called osteoprotein that to be highly expressed in the eyes from patients with diabetic retinopathy. Then we decided to do an extensive study to explore its role in the pathogenesis of the disease, particularly in the process of angiogenesis or neovascularization, which is a hallmark feature of proliferative diabetic retinopathy, as well as inflammation. And as I'm going to discuss today, there is a very strong element of inflammation present in the eyes of these patients. In fact, these studies were done in 3 laboratories. The laboratory of Riga Institute for Medical Research, led by Professor Sophie Straf, Professor Rezlan Abdunakar, and Professor Geert de Hertog. And also in the laboratory of Professor Rafael Simo, who is director of Diabetes and Metabolism Research Institute, Barcelona, Spain. He is recently collaborating with us in our research. So the paper, we put all the data together, and the first paper was recently published in Investigative Ophthalmology and Visual Science. So what I'm going to do today is to give you a summary of this research. In addition, this paper was funded by Diabetes Research Fund, which is an European funding agent. They approached us and they told us they are willing to sponsor, to support, to fund our research, and we received also funding from this funding agent for this research. So if we talk about proliferative diabetic retinopathy, what are the hallmark features of proliferative retinopathy? Ischemia, induced angiogenesis, and expansion. So the process starts with neovascularization. Ischemia, induced angiogenesis. We have recently published an important research to show that when you look at the diabetic eye, proliferative diabetic retinopathy early in the course of the disease, you see all the new vessels. If the patient is not treated with laser foot coagulation, then the new vessels will be accompanied by fibrous tissue, so have a fibrous component. I was asking myself for many years, what is the relation between angiogenesis and then fibrosis? And recently we identified a novel mechanism where angiogenesis causes fibrosis. We demonstrated that activated endothelial cells in the angiogenic vessels can transform into myofibroblasts or mesenchymal cells. This is a process called endothelial mesenchymal transition. And we identified what are the regulators of this endothelial mesenchymal transition. So we started by angiogenesis and we end with fibrosis. So if you see an end stage, the proliferative retinopathy, you see only white fibrous tissue, and the new vessels will regress. So we showed that the endothelial cells, the activated endothelial cells of the angiogenic vessels, they can transform into mesenchymal cells or myofibroblasts, which are the activated fibroblasts. These are the cells that produce extracellular matrix proteins and cause fibrosis. So it starts with ischemia-induced angiogenesis, followed by fibrovascular proliferation, and formation of fibrovascular membranes at the vitreoretinal interface that will lead to a blinding complication like diabetic vitreous hemorrhage and or traction retinal detachment. If we look at the whole picture of the disease, we have pathologic growth of new blood vessels, proliferation of alpha smooth muscle actin expressing myofibroblasts. So we have myofibroblasts which are activated fibroblasts. We have infiltration, I'm going to show you, infiltration of inflammatory leukocytes. So we have inflammation, leukocytes, expressing common leukocyte antigen CD45 and the myeloid marker CD11P. This is in addition to the local production of pro-inflammatory cytokines, chemokines, and matrix metalloproteinases. And these are playing significant role in disease progression. I'm going to discuss later what is the role of each of these molecules. For many years, I'm spending hours and hours in looking at the fibrovascular tissue that we excise from the retina at the time of repair of traction retinal detachment. And we identified three major elements in these membranes, and these are new blood vessels, alpha smooth muscle actin expressing myofibroblasts, and leukocytes. This is an example. This is when you do immunohistochemistry, you have to do a negative control using a relevant antibody or using the whole procedure, the same procedure, staining, but omitting the antibody. Then if there is no staining, you know that your staining protocol is specific. And these two slides are stained for CD31. What is CD31? This is a specific marker of endothelial cells. And then just to show you that we have so many, all this staining is in new blood vessels. So you can see these membranes are full of new blood vessels or angiogenic blood vessels. And we count these vessels to have an idea about the proliferative activity of this particular specimen. Then this is staining for CD45. And then all these red cells are leukocytes. So you can see these membranes are full of leukocytes. There is a very important inflammatory response in the tissue that we excise at the time of vitrectomy. And this is staining for another marker of myeloid cells, CD11P. And this is staining for alpha smooth muscle actin. And then you can see many spindle-shaped cells. And these are myofibroblasts, or the cells that produce extracellular matrix proteins and cause fibrosis. So several studies, including ours, showed the overexpression of angiogenic. In addition to this staining, there is overexpression of angiogenic, inflammatory, and fibrogenic factors in the ocular microenvironments of patients with proliferative retinopathy. This finding suggests that neovascularization, inflammation, and fibrosis are critical for BDR progression. So many studies and early studies that published in 2004 showed that in the course of, if you induce diabetes in animals, in experimental animals, and the best example is streptozotocin, diabetic animals. Streptozotocin is a molecule when you inject it intraperitoneal, you damage pancreatic cells. So it is a model of type 1 diabetes. The studies, it was one of the first study to show that in the diabetic retina of these animals, there is chronic low-grade subclinical inflammation. And this has been shown to play a central role in the development of diabetic retinopathy. So this study showed that diabetic retinal vascular leakage, which is an early phenomenon, capillary number fusion, and endothelial cell damage are associated with retinal leukocytic stasis. So you see a lot of leukocytes adhering to the vascular endothelium. This is what we call leukocytic stasis, which is an early phenomenon in the diabetic retina. Why we have this retinal leukocytic stasis? This is because the endothelial cells of the retinal blood vessels are activated, and they express adhesion molecules, the best example of which is called ICAM1 or intercellular adhesion molecule 1. So if you have upregulation of the adhesion molecules induced by hyperglycemia, on the vascular endothelial cells, this will allow the leukocytes to adhere to the endothelial cells and causes leukostasis. And this leukostasis will cause damage of the endothelial cells through oxidative stress and other mechanisms. And this is the reason why we have early breakdown of the blood retinal barrier. It's the process of leukostasis. So this finding suggests that leukocytes play important role in the pathophysiologic development of diabetic retinopathy. Moreover, cancer research, we always look at the results from cancer research because we can apply the results from cancer research to also what we see in diabetic retina. So cancer research showed a very strong, important mechanistic link between inflammation and angiogenesis. So chronic inflammation will cause angiogenesis. When Dr. Tabara was talking during the seminar on angiogenesis of the cornea, I wanted to make a comment about this because chronic inflammatory conditions of the cornea will induce angiogenesis. You agree, Dr. Samar? And because you see it in herpetic keratitis and in other inflammatory conditions. So there is a very important mechanistic link between inflammation and angiogenesis. Therefore, an important emerging issue in proliferative diabetic retinopathy is the research is to focus on identifying new molecules that can bridge the gap between inflammation and angiogenesis. And that's what we are doing these days. So what is angiogenesis? Angiogenesis means sprouting of new blood vessels from pre-existing ones. Okay. It's a multi-step process. To have angiogenesis, it is a multi-step process that requires degradation of the basement membrane and the extracellular matrix. Why is that? Because you need the endothelial cells, they need to infiltrate through the basement membrane and extracellular matrix to form new vessels. So you have the first step, you need degradation of the basement membrane and extracellular matrix. Second, you need endothelial cell migration. So the endothelial cells need to be activated to migrate. Then endothelial cell proliferation. And then the endothelial cells will form capillary tube formation or new vessels. These are the requirements for angiogenesis. So to form new blood vessels, activated endothelial cells must degrade the basement membrane of the original vessels and remodel the extracellular matrix. How this can happen? This can happen with the help of enzymes like proteases. So these enzymes or the proteases will cause the degradation of the basement membrane extracellular matrix. And the most important group of these proteases are matrix metalloproteinases. It's a very big group of enzymes. But recently, we did again screening for the vitreous from patients with proliferative retinopathy, and we identified only 3 matrix metalloproteinases to be upregulated in diabetic retinopathy. And these are matrix metalloproteinase 1, matrix metalloproteinase 7, and the matrix metalloproteinase 9. And this upregulation of these 3 matrix metalloproteinases was associated with angiogenesis and progression of diabetic retinopathy. Now, matrix metalloproteinases, they also serve other functions, especially matrix metalloproteinase 9. By itself can induce VEGF, vascular endothelial growth factor. This is number 1. And then matrix metalloproteinase, now you know, VEGF in quiescent eyes or in quiescent tissue is bound to the extracellular matrix, is not released. But matrix metalloproteinases will cause proteolytic release of vascular endothelial growth factor from the extracellular matrix associated reservoirs. And this resulting in increased VEGF bioavailability and triggering the VEGF-driven angiogenic switch. This term angiogenic switch is very important to keep in mind. Why? That was produced, or the term was introduced by Han and associates in a journal called Cell in 1996. The angiogenic switch means that we have in our body, we have a balance between pro-angiogenic and anti-angiogenic factors, molecules that produce angiogenesis and molecules that inhibit angiogenesis. One of the famous angiogenic factors is VEGF. And one of the famous anti-angiogenic factor is vascular endothelial, retinal pigment epithelium-derived factor. So this will regulate angiogenesis. If there is upset in favor of angiogenesis, that more angiogenic factors are produced, you will have angiogenesis. If there is more anti-angiogenic factors, this will shift the equilibrium to vessel quiescence. We know that VEGF is one of the most famous angiogenic factors, and not only angiogenic, but it is also called vascular permeability factor because it causes also breakdown of the blood retinal barrier. But keep in mind, this is a recent publication in Proceeding National Academic Science of USA 2007. They showed that there are many angiogenic factors, not only VEGF. If you block VEGF to treat cancer, you have upregulation of other angiogenic factors. So that means that to give effective treatment, blocking VEGF is not enough, because if you block VEGF, you have upregulation of other angiogenic factors. So angiogenesis depends on multiple factors, and when the activity of one angiogenic factor such as VEGF is suppressed, the expression of other angiogenic factors may appear. That's why we need to know what are the other angiogenic factors that can be involved in diabetic retinopathy. And we know that therapeutic regulation of angiogenesis has emerged as an attractive approach for the treatment of proliferative diabetic retinopathy, and to aid the progress of anti-angiogenic therapies, a more comprehensive understanding of additional molecules regulating angiogenesis in proliferative diabetic retinopathy is important. And as I said, during the process of screening for angiogenic factors, we identified osteoprotergine. So what is osteoprotergine? It is a novel regulator of endothelial cell function, angiogenesis, and vasculogenesis. What is vasculogenesis? The process of formation of new blood vessels depends on two mechanisms: angiogenesis, which are sprouting or formation of new blood vessels from the pre-existing blood vessels in the tissue. But what is vasculogenesis? We showed previously that vasculogenesis also is involved in the formation of new vessels in diabetic retinopathy. Vasculogenesis means that recruitment of endothelial progenitor cells from the bone marrow, they're coming from the blood, into ischemic area where they transform into endothelial cells and form new blood vessels. So the two processes are happening in diabetic patients: angiogenesis and vasculogenesis. Formation of new blood vessels from the already existing blood vessels, and formation of new blood vessels from endothelial circulating endothelial progenitor cells derived from the bone marrow that migrate into ischemic area, not only in the eye, but other ischemic area also, where they transform into endothelial cells. So osteoprotergine regulates both angiogenesis and vasculogenesis. It is a member of the tumor necrosis factor receptor super family, and in fact it was initially identified for its role in regulating bone metabolism. That's why it's called osteoprotergine. But more recently, it has been shown that to have additional rules in regulating endothelial cell function in tumor angiogenesis and vascular disease. So the expression of osteoprotergine in diabetic retinopathy has not been reported so far. Given the key roles of osteoprotergine in regulating endothelial cell function and promotion of angiogenesis, we investigated the hypothesis that osteoprotergine may be involved in angiogenesis in proliferative diabetic retinopathy. It is not only angiogenic factor, but I'm going to show also that it is also an inflammatory factor, and I'm going to show you also evidence that it is involved in the inflammatory process that happen in the diabetic retina. So to examine the role of osteoprotergine, we studied vitreous fluid samples and epiretinal membrane specimens from patients We studied human postmortem eyes. And that's why we collaborated with Professor Simo, Rafael Simo, from Barcelona, Spain, because I met him in one of the international meetings, and he told me that he can help me by examining human postmortem eyes. He has access to human postmortem eyes. We studied, we used the ELISA technique, we used the Western blot analysis, we used immunohistochemical stainings, we used the immunofluorescence. And Professor Sophie Straff, she did the angiogenic assays to see if osteoprotein can induce angiogenesis using human retinal microvascular cells. So if you look at the results, this is immunohistochemistry, this is OBG, osteoprotein, this is the control, this is proliferative diabetic retinopathy. So there was significant upregulation of osteoprotein in diabetic vitreous samples. If we look at VEGF, again, you see very strong upregulation of VEGF in diabetic samples compared to control samples. If you look at monocyte chemotactic protein 1, we use it as a marker of inflammation. It is an important inflammatory chemokine, which is also angiogenic. And if the name indicates monocyte chemotactic protein 1, it is chemoattractant for monocyte macrophages. So it is also significantly upregulated. So why we do this? Because we want to see how osteoprotein correlate with VEGF as an angiogenic marker, and how osteoprotein correlate with monocyte chemotactic protein as an inflammatory biomarker. And then we showed a significant positive correlation between the levels of osteoprotein and vascular endothelial growth factor and osteoprotein and monocyte chemotactic protein 1. Then to confirm, and this is very important nowadays in research, you need to confirm the presence of a molecule by more than one investigation. So we did another technique called the Western blot analysis. Western blot is another technique to look at the expression of a protein. So osteoprotein molecular weight is 50 kilodalton. Then we did Western blot analysis of the vitreous samples. This is control. This is diabetes, control, diabetes, control, diabetes. You see, the band is stronger in diabetic samples. Then we did quantitation analysis, and again we showed that using another technique like Western blot, we have upregulation of osteoprotein in the ocular samples. Then we did immunohistochemistry in the membranes, pre-retinal fibrovascular membranes. This is negative control, no staining. This is again to show you the CD31, which is a marker for endothelial cells, showing many new vessels in these membranes. So these are angiogenic or vasculogenic vessels. We count these vessels to have to correlate with the expression of osteoprotein. Counting these vessels in a membrane will tell us about the proliferative activity, if this is an active membrane or involuted membrane. And these are leukocytes, CD45, alpha smooth muscle actin. Then you can see osteoprotein, very nicely expressed by endothelial cells. And then it is also expressed by myofibroblasts, spindle-shaped cells. And then when we did double staining, we have leukocytes expressing osteoprotein. Then when we looked at the correlations, we found a positive correlation between osteoprotein expression in the membranes and the amount of vascularization based on counting the new blood vessels. So again, this is again another piece of information to tell us that osteoprotein involved angiogenesis. Then we were asked by the reviewers to study another type of tissues as a control. So we did a staining for another membrane. What is the other membrane that we can excise at the time of surgery, vitreoretinal surgery? Which type? Which type of disease? BVR, proliferative vitreoretinopathy. This is the other tissue that we peel from the eye. Then BVR or pre-retinal, I always tell the residents and fellows that proliferative vitreoretinopathy membranes are totally different from that of proliferative diabetic retinopathy membrane. The BVR membranes are fibrocellular, but the BDR membranes are fibrovascular. So we did the staining for CD31, no blood vessels. We did the staining for alpha smooth muscle actin. These membranes also are full of myofibroblasts. You can see the spindle-shaped myofibroblasts. We did the staining for leukocytes, a lot of leukocytes, but no osteopoturgene. So osteopoturgene was specific for proliferative diabetic retinopathy and not for proliferative vitreoretinopathy. Then, in the laboratory of Professor Rafael Simo in Barcelona, he examined human retina from diabetes and controls. And then, again, another way to look at the expression of the molecule is to look at the messenger RNA of the molecule. So he looked at the messenger RNA of osteopoturgene. And he could examine retinal pigment epithelium alone and neuroretina alone, and then he showed a significant upregulation of osteopoturgene both in the retinal pigment epithelium and neuroretina. Then he did also Western blot, as we did, and by Western blot, he showed that osteopoturgene, this is to look at the protein, because you can look at the molecule at the messenger RNA level, transcriptional level, as well as at the protein. Protein is the fruit. So he showed that the protein also using, this is control retina, this is diabetic retina. So osteopoturgene was upregulated both in the retinal pigment epithelium and neuroretina. Then he did immunofluorescence to localize the osteopoturgene in the retina. Here, this is the RBE, outer nuclear layer, inner nuclear layer, and retinal ganglion cell layer. This is control, this is diabetes. Osteopoturgene is red, so is green. So you can see upregulation of the green in diabetic. So there is more osteopoturgene in diabetic retina. But this is a double staining, combining osteopoturgene and glial fibrillary acidic protein. Glial fibrillary acidic protein is a marker for glial cells. And a very early phenomena in diabetic retinopathy is activation of glial cells. Then you can see in control, as we have shown many years ago, the staining the red of glial cells is present only in the inner retinal layer, and these are in astrocytes. Because molar cells, when quiescent, they don't express glial fibrillary acidic protein. But molar cells, when activated, and this is a very important marker of inflammation, the diabetic retina, they express glial fibrillary acidic protein. So here you can see that the staining for GFAP, you have this radial distribution of molar cell processes. So that means that in a diabetic retina, we have activation of glial cells or molar cells, which is an early phenomenon in diabetic retina. Then we wanted to see if also glial cells can express osteopoturgene, the only way to do double staining. So this is staining for osteopoturgene green. This is staining for GFAP for glial cells. You can see molar cells staining. And then the merge or the double staining, so you can see the yellowish, the combination of green and red will cause yellowish. So you can see the co-localization of osteopoturgene and the glial fibrillary acidic protein. So osteopoturgene, meaning that it's produced by glial cells, like molar cells. Then we used another marker for microglia. Another cell present in the retina is microglia. It is the monocyte macrophages of the retina. Again, these are a marker for microglia, IPA1, and you can see the microglia. These are like monocyte macrophages. And then you have the merge that tells us that osteopoturgene is expressed also in microglia. And then collagen 4, which will stain the vascular structure. So you can see also co-localization between vascular structure and osteopoturgene. So in these experiments, we identified that in the human post-mortem eyes, there is upregulation of osteopoturgene in the diabetic retina, and the expression is by glial cells, microglia, and also vascular structures. Then in the laboratory of Professor Sophie Straff, she did the in vitro studies using human retinal macrovascular endothelial cells. You remember I showed you in immunohistochemistry that osteoprotein was expressed by endothelial cells, right? We wanted to see if in vitro, if we wanted to confirm if really endothelial cells can produce osteoprotein. So we did in vitro studies using human retinal macrovascular endothelial cells in culture to see if they can produce osteoprotein. And here she is showing that thrombin had no effect. Why did she use thrombin? Because previously we identified upregulated level of thrombin in the eye from in the vitreous samples from patients with proliferative retinopathy. MCB1 has no effect. VEGF has no effect on the induction of osteoprotein. But the pro-inflammatory cytokines, this is very important, but the pro-inflammatory cytokines, interleukin 1 beta, TNF alpha, and the combination interleukin 1 beta and TNF alpha strongly induced osteoprotein. That means that osteoprotein is induced by inflammation in the diabetic retina. And I mentioned earlier that we have a strong inflammatory component in the diabetic retina. So the only molecules that cause the upregulation of osteoprotein in endothelial cells were pro-inflammatory cytokines, IL-1 beta, TNF alpha, and the combination IL-1 beta and TNF alpha. She also looked at combinations of thrombin and VEGF, MSCB1 and VEGF with no effect. Then you remember I told you that a key early component of angiogenesis is endothelial cell migration, right? You need endothelial cell to migrate out of the original vessels to form new vessels. Then we tested the cells in vitro. We exposed the endothelial cells to different concentration of osteoprotein, and she showed that at the concentration of 20 nanogram per ml and 100 nanogram per ml, osteoprotein induced endothelial cell migration. And this amount of endothelial cell migration was comparable to that induced by VEGF. This is in vitro. So osteoprotein was able to induce endothelial cell migration, which is a key early step for angiogenesis. Now, to have angiogenesis, you need activation of signaling pathways like AKT and ARC. Then she showed that osteoprotein was able to induce these signaling pathways because these are survival and proliferating signaling pathways. Then we used an in vivo model of angiogenesis where you implant matrigel subcutaneously in mice. Then you can put the matrigel without any addition. You can, and then you can add to this matrigel VEGF. You can add to this matrigel osteoprotein, and you can add to this matrigel osteoprotein and VEGF. And then you put this matrigel subcutaneously in the mice, and then after a few days you take it out and you analyze the blood vessels present in this matrigel. This is an in vivo model for angiogenesis. So theoretically, when you implant something containing high concentration of VEGF, you would expect to have new vessels migrating into these matrigels and so on. So we showed that VEGF alone did not induce significant upregulation of angiogenesis. OPG alone did not cause significant upregulation, but the combination was very interesting. The combination has a synergistic effect to cause angiogenesis in vivo. And then, you remember in the vitreous analysis, we could show that we have upregulation of both osteoprotein and VEGF. So in the eye, we have this combination working together. VEGF by itself was not able to induce it. Osteoprotein by itself was not able to induce it. But the combination VEGF and osteoprotein will cause upregulation of in vivo angiogenesis. So, and then in our lab, we wanted to see, can osteoprotergine, I told you earlier that osteoprotergine is induced by inflammation because only pro-inflammatory cytokines cause upregulation of osteoprotergine in endothelial cells. Now, we wanted to see, can osteoprotergine induce the inflammation in the vascular endothelial cells that can lead to leukostasis? Leukostasis is an early phenomenon which is due to activation of endothelial cells by upregulating adhesion molecules that will allow the circulating leukocytes to adhere to the endothelial cells. Then we treated the cells, human retinal endothelial cells, with this is control with osteoprotergine. And then we did Western blot. We could see that osteoprotergine induced upregulation of the adhesion molecule ICAM1, the one that induced leukocytic stasis. Not only ICAM1, but there is another adhesion molecule called VCAM1, vascular cell adhesion molecule 1, was upregulated by osteoprotergine. So osteoprotergine has two major functions: angiogenesis, vasculogenesis, neovascularization, and inflammation of the endothelial cells. So in the patient study, we showed that osteoprotergine was significantly upregulated in the vitreous fluid from patients with proliferative retinopathy and in the retinas from subjects with diabetes. This is the first step we start with. We want to see if this molecule is upregulated. Using immunohistochemistry, we demonstrated that the osteoprotergine protein was specifically produced by vascular endothelial cells, and we confirmed this in vitro, myofibroblasts, and leukocytes in fibrovascular epiretinal membrane. And these are the three major components of the cells present in these membranes: angiogenic blood vessels, leukocytes inflammation, myofibroblasts fibrosis. So although osteoprotergine was first described as a modulator of bone metabolism, an increasing number of reports now consider that osteoprotergine also has a function in other biological systems, including promotion of angiogenesis and vasculogenesis. As I said, the angiogenic process requires activation and the invasion of endothelial cells through their basement membrane, followed by proliferation, migration, and re-establishment of cell-cell contacts to form patent tubes. It has been shown that osteoprotergine contributes to all these events. So osteoprotergine, as I showed, it is involved in vitro and in vivo angiogenesis. Other studies, earlier studies published in Molecular Cancer 2009, they showed that osteoprotergine enhances the pro-angiogenic effect of VEGF. And we showed also this. This is in agreement. So our findings that the osteoprotergine enhances the angiogenic effect of VEGF is in agreement with this earlier study. So we showed that osteoprotergine induced human retinal macrovascular cell migration, which is, as I said, early step of angiogenesis. In addition, we showed that osteoprotergine can activate proliferative, what's called signaling pathways, ARC1, 2, and survival signaling pathway, which is called AKT in human retinal macrovascular cells, which is another proof that of the angiogenic effect. As I said, we have chronic low-grade subclinical inflammation very early in the course of diabetic retinopathy. And we have shown that osteoprotergine is induced by pro-inflammatory markers, cytokines like TNF-alpha, IL-1 beta. So these findings suggest that inflammation might be involved in diabetes-induced retinal endothelial structural damage by inducing osteoprotergine expression. It has been shown in previous studies that osteoprotergine also is upregulated in inflammatory diseases, making osteoprotergine as a good biomarker for inflammation. Therefore, we wanted to see if osteoprotergine can induce the inflammation and activation of endothelial cells, and we showed indeed that osteoprotergine can induce the upregulation of adhesion molecules ICAM1 and VCAM1 on endothelial cells. Because we know that increased leukocytic endothelial interaction is a very early phenomenon in diabetic retinopathy. This finding suggests that the osteoportogene is playing a pathological role in the ocular microenvironment of patients with diabetic retinopathy and contributing to the inflammatory status of the endothelium. So in conclusion, our findings suggest that osteoportogene may be specifically involved in promoting progression of pathologic neovascularization in the ocular microenvironment of proliferative diabetic retinopathy patients. This means that therapeutic strategies aimed to decrease osteoportogene levels may be suitable for improving the vascular function in diabetic retina. Thank you very much for your attention.
Thank you, Professor Abdul-Aslam. We open the floor for discussion. Any questions? Dr. Sasson.
Most of the patients that we operate for complication of the diabetic retinopathy are for proliferative diabetic retinopathy. Very difficult here, Savsan, when you have a patient with vitreous hemorrhage or diabetic traction retinal detachment, is to know. So what we usually look at the activity of the BDR, if it is quiescent, if it is or involuted, or it is active. And this, we do this by counting the blood vessels present in the pre-retinal membranes. So we can tell, okay, we are dealing with a sample from a patient with active angiogenesis, or a sample from a patient with involuted diabetic retinopathy. This is one of the studies that we are planning to do. You can do this in two ways. In vitro, by examining its effect on the permeability of human retinal microvascular endothelial cells, using a technique called transelectrical resistance. And in vivo, by injecting into the eye of rats, healthy rats, and then look at its effect on the blood retinal barrier breakdown.
Thank you, Professor. Can you hear me?
Yes.
Thank you, Professor Abdul-Asrar, for this presentation. And then also about highlighting that the similarity between the retina and the cornea with regards to neovascularization. Just
No, what I wanted to say is that angiogenesis or neovascularization is the same
Concept,
in
the
cancer,
concept.
in the cornea. In fact, my colleagues in Leuven, they study as a model of angiogenesis. They insert into the cornea pellets containing the molecules that they are studying. And then they look at the amount of neovascularization coming into these pellets.
Okay.
So they quantitate the amount of neovascularization and then they can tell, okay, this molecule is angiogenic, this is anti-angiogenic. It is a well-known cornea model. It's a well-known model of angiogenesis, to study angiogenic molecules.
Yes. So we're talking about this new one, the osteoprogesterone. So my question is that, is there any like predilection for certain organs to the VEGF or to this osteoprogesterone? Meaning why, like there are certain, like for the eye, we know that in the cornea, periphery of the cornea, we have the retina. There are certain area where the VEGF or this new one are.
But you cannot tell this.
Or something that
Yeah.
are regulated in certain diseases.
You cannot
something
tell
like that.
this unless you examine corneal tissue.
Yeah.
And this is easy. If you have cornea from patients with angiogenesis,
Yes.
and I'm sure you will have many of these
We had.
at the time of keratoplasty, and then you can look for osteoproteogene. You have different ways, as we did here, messenger RNA. You can do Western blot. You can do immunohistochemistry of this cornea, staining of the
Yes.
cornea.
Yes.
There are so many ways to do this.
because you know
And I would be interested that if you do
to
this.
do this one. This is why, because we followed the steps of the retina people, and we started to use the anti-VEGF only after the translational research
Yeah.
came up with this data from the retina colleagues. Yes.
Yeah.
So we'd love to know. So you are now aware of any ongoing translation?
Any other ocular tissue. In fact, this is
Yes.
the first study on osteoprotergine
In the eye.
in the eye, in diabetic retinopathy especially.
Thank you.
Dr. Farah.
Thank you very much, Professor Usrar. Now, practically, when I see very aggressive NVI in a diabetic patient, and then once we inject anti-VEGF intraocularly, in a day or two, the blood vessels, they
Yes.
regress. So that's what I think. Now, always I'm thinking that probably VEGF is the main one, either through other cytokines or a final common pathway for most of the angiogenesis. And it is really a magic. Once these blood vessels on the iris, very aggressive, and then after only a day or so, after the injection of anti-VEGF, all seems very quiet. What do you think about it? Is it the main player or other cytokines through it, or probably in the eye at least? I know that many sort of proliferative diseases we deal with anti-VEGF, or are these other vasculogenesis are not very active as the VEGF?
When we look at cancer, as I said, they showed nicely that if you block VEGF, there is other angiogenic factors produced that cause progression of the disease. So for sure, VEGF, this is most famous, but this is not the only molecule. And there are many other molecules involved in this process, but it is important factor, but it is not the only one.
Because when we block it in the eye, at least, even we follow with frequent injections that there are no activity. So probably other.
But we don't
phase
give
one-
these patients lifelong treatment. We only, at least in our hands, we give only one injection, then we give laser, and then we'll do trabeculectomy for this patient if they have neovascular glaucoma.
Yes.
But it is only one injection that we give. It is not lifelong treatment.
No, now there are sort of uses of in PDR or in macular edema of anti-VEGF alone. So what about these other cytokines? They are not produced, or
They are
if they are
present.
produced, we will see the.
They are present. But perhaps if you follow these patients long, you will see the escape phenomena that the patient, the new visits will recur despite anti-VEGF agents.
Thank
Prof, thank you very much for this very informative lecture, which showed clearly the molecular biology background for proliferative diabetic retinopathy. And in continuity with the concern of Dr. Sousan Wailati, whether there is a contribution for inflammation in the process of macular edema, I think from our clinical observation, yes. For example, if we give anti-VEGF, whether Lucentis, Avastin, or Eylea for diabetic macular edema, it will work for 4 to 6 weeks maximum. Then you need to repeat it. But if you augment this with triamcinolone, subtenon, usually I use periocular because it is safer than intraocular, it elongates the effect of macular dryness, which means that there is also inflammatory component for diabetic macular edema.
Yeah, but this is something well known for many years. The inflammatory component, if you inject one eye with anti-VEGF and the fellow eye with triamcinolone, next day that eye that had triamcinolone is dry, not the other eye. Personally, I never saw a patient with macular edema who was controlled only with anti-VEGF, or who is dry 100% with anti-VEGF. I never. Perhaps our patients are different from those patients, including other studies. But I never saw, I had a patient, I received many patients coming from other institutes. يقول لك, and I had 12 injections, 16 injections, but he still have very severe macular edema. So, but if you inject a triamcinolone steroid in this eye, it responds very quickly. But of course, with a lot of side effects. But this is again, it proves the concept that inflammation is very important in the pathogenesis of this disease.
So, thank you very much for this informative data. But would you consider using a combination of anti-inflammatory?
This is now, yes, this is now the people are thinking about it.
Yes.
Like I think the companies that produce Eylea, they are producing a new drug they wanted us to participate in their trial, combining two molecules, not only anti-VEGF, but another anti-angiotensin. So combining these molecules in one drug. So now this is the trend now, is to have combination of anti-angiogenic factors.
And especially if the new anti-osteogenic factors are
Yes.
discovered, you can add them also.
Yes.
And you'd have a complete
Yeah.
array.
But these studies are very early,
Yes.
because we just wanted to see which molecules are upregulated, and then perhaps one of these molecules can be used as a therapeutic target.
Combination treatment
Yes.
of all three.
Yeah.
Thank you very much.
Shukran.
With this, we conclude our grand round. Thank you very much.
Shukran.
نفس الشيء.
السلام عليكم ورحمة الله وبركاته. Are you ready شباب؟ This is the first question. Young gentleman, status post severe blunt trauma to the right eye. His visual acuity for this eye is no light perception. What is the diagnosis? ما واضح؟ قدم الله. Is it clear or no? Status post severe blunt trauma to the right eye, and he has no light perception. What is the diagnosis, or what's the cause of no light perception? Number 2, this is the OCT of old lady, known case of diabetic. What is the OCT finding? And give me 2 options of treatment. What's the OCT finding and 2 options of treatment? Question number 3. What is the clinical sign? And give me 3 causes of this disease or this pathology. What is the sign, or what's the clinical sign, and 3 causes of this disease? Question number 4. Same patient underwent one procedure. Name this procedure and give me 1 complication of it. What's the procedure that he underwent and 1 complication of it? Last question. Young boy, what's the diagnosis, mode of inheritance, and what's the stage? Do you need to repeat or it's okay? Okay. Can we collect the paper? Do you want to do the answer now or after break? Who answered this question? يلا. So diagnosis. Muhammad, say diagnosis. Yeah, this is very clear. I mean, rarely to see optic nerve revulsion very clear like this picture. And you can very clearly we can see the retina. It's all drawing toward the optic nerve revulsion. Any volunteer? Vitreomacular traction. 2 options of treatment. Intravitreal injection, mechanical movement of the traction, or barzapanifictomy. So subhyaloid hemorrhage, any causes? Blunt trauma, any causing of layer hemorrhage, retinal artery macronism, choroidal vascular membrane can. What's the procedure? Yeah, laser hydrotomy. Complication or retinal defect or trauma. Usually it's safe procedure, and if you can see how we choose the inferior part to apply the laser. But can cause retinal defect, choroidal hemorrhage, retinal hemorrhage. Last one, diagnosis. Mode of inheritance. What's the stage? شكرا حبيبتي. What's that? Vitiliform. Vitiliform. Egg yolk stock. Okay. يعطيكم العافية.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم وصلى الله وسلم على محمد وعلى أصحابه أجمعين. Today I will present a case which is I found it interesting and it happened in one of my own calls. The story started around midnight in one of my own calls. Me and our great second on call, Dr. Ayman Sharif. We had 23 years old male who is medically free, presented with a trauma to the left eye by a metallic hanger while turning his head. No loss of consciousness or vomiting or change of vision or flashes or floaters after the trauma, but he reported a history of gradual decrease of vision in the right eye over 1 month. He denied taking any medications or drugs, and he is only allergic to stems, which cause itchiness. And patient reported multiple bruises and history of forearm fracture 2 months ago and generalized fatigue. We can describe here the lid laceration as superficial, measuring 4 by 2 millimeter. It was not involving the lacrimal system or lid margin. So he presented a trauma to the left eye, but what was wondering in the history, the decreased vision in the right eye. On physical examination, the right eye, he has a visual acuity of counting finger at 1 feet, and the left eye, it was 20/40 with pinhole 20/25. The IOP was within normal and full extraocular motility, and the pupil reaction and reflexes were within normal without relative afferent pupillary defect. On slit lamp examination of the right eye, anterior segment was within normal in the right eye, but the fundus photo in the right eye, we can see multiple hemorrhages in the retina and multi-layered hemorrhage and flame-shaped hemorrhage, and also at the fovea there is intraretinal hemorrhage. In the left eye also there is flame-shaped hemorrhage. So our impression was hematologic-related retinopathy and left upper lid superficial laceration. So we contacted our third on-call, and he advised to do STAT, CBC, and coagulation profile, and ESR, and renal function, and liver function. Then they called me, the hematology, to report a critical result of CBC. It was low, severely low hemoglobin, 4.7, and WBC was low normal and platelet 7,000, and the normal should be above 100,000. And absolute count of neutrophils was low. So the picture was pancytopenia. So I called the medical on call, and he advised to call the patient again and to give him urgent referral to KKESH for urgent blood transfusion, including platelets and fresh frozen plasma and workup. In the history, he denied taking any medications and highlighted by red line. But when he went to KKESH, he admit history of alcohol intake and hashish, Chinese pills, multiple sexual partners, and they did for him HIV serology and syphilis. All were within normal, and it was negative. Also hepatitis. So their final diagnosis was aplastic anemia, bone marrow suppression secondary to alcohol. Unfortunately, the patient refused to complete the treatment, and he signed a DAMA, and he will continue his treatment in Jeddah. This is his OCT in the right eye. You can see here at the fovea. That's why the vision was counting finger. Here, intraretinal hemorrhages in the central of fovea. The left eye, it was not central in the fovea, but it was around the fovea, so that the VA was okay in the left eye. So aplastic anemia is a critical, life-threatening condition, and characterized by pancytopenia and hypoplastic bone marrow. Most common causes are insecticides or drug intake, like in our patient. I reviewed the literature, and I found this useful article. It was a study conducted in 5 centers, 5 referral centers, and they found only 18 cases with aplastic anemia. This was the demographic of the patients. And they found the ocular findings in 18 patients. The most common was pre-retinal hemorrhages, and followed by cotton wool spots and vitreous hemorrhage in 13%, and picture resembling CRVO, it was 13%, and optic disc edema, 6%. So their conclusion, a blood profile is needed in any patient with unexplained retinal hemorrhages, and patients with aplastic anemia need to avoid ocular massage and Valsalva maneuver to decrease ocular morbidity. In this study, they found ocular findings in 14 patients out of 18. Bilaterality was in 8 cases, and 6 cases were unilateral. And these findings were regressed in 5 cases after multiple blood transfusion. And patients, after positive eye findings, some of them, they might develop complication which lead to death. One of the patients died due to cerebrovascular accident within 2 weeks. Second patient with pericardial bleeding after 3 weeks. One of them, cytomegalovirus pneumonitis in 6 weeks. Then intracerebral bleeding and extreme severe anemia. This patient, they did for him head CT, it was within normal, alhamdulillah. The hematologic profile in these patients was in the average 5.5, the hemoglobin, and platelet was 26.5 thousands. Our patient was 7,000. When do these manifestations appear? Retinal vein becomes dilated and tortuous, with the degree of retinal vein dilation correlating with the severity of the anemia. And they found that cotton wool spots will appear if the hemoglobin is less than 7.8. Also, retinal hemorrhages will present if the hemoglobin less than 7, but it's also related to age, the retinal hemorrhages. In case of combined, I mean thrombocytopenia and anemia, the patient will present with pre-retinal hemorrhage and vitreous hemorrhage. This is a picture just to clarify growth spots here. Also, this is a picture of growth spot. This is of the other picture, multiple bilateral nerve fiber layer hemorrhage and pre-retinal hemorrhage involving the macula in a 14-year-old girl. The other presentation, as what I said, central retinal vein occlusion like picture, and here perimacular betaloid hemorrhage. I hope this case was important. So just to emphasize, any unexplained retinal hemorrhage, we should investigate, and we do routine labs like CBC and investigate for the cause. And if we treat the cause, most likely in aplastic anemia, patients will improve. Thank you all.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. My name is Abdurrahman Faleh, and I would like to thank Dr. Abdurrahman Faran for supervising me. So on 15th of 5/2017, preterm baby referred from Braida Hospital, gestational age 27 week, and corrected 32 weeks. Body weight was 900. At presentation, it was 1.1 kg on supplemental oxygen. On examination, cornea was clear, DBC. Fundus examination showed severe plus, zone 1, stage 1. Impression was aggressive posterior, ROP, both eyes. The plan was examination under anesthesia with photos and intravitreal anti-VEGF, both eyes. And next follow-up will be ENER, then in the clinic. So this is the, at the same day, this is the fundus photos by RITCAM, both eyes, showing aggressive posterior, ROP, and zone 1. And here is the severe plus, tortuous blood vessels with dilated veins. Regarding, you see the stage, you cannot define the stage. This is one of the characteristic of aggressive posterior. Next follow-up, fundus examination was done after injection. There was no plus, still in zone 1 and stage 1. Also, there is the plan was to observe. The next examination was after 10 days. It was with zone 2 and stage 2. After observation, 10 days, still in zone 2, but in stage 3. And this is actually by another doctor because Dr. Abdurrahman was taking on leave that day. So after 10 days also, zone 2, stage 2. The follow-up was between 1 week and 10 days. Still zone 2, stage 2. 9 of July was still zone 2 and stage 2. After 10 days, the same. 10 days also, the same. Then on examination, after maybe 3 months of follow-up, he reached zone 3 with the stage 1. The right eye, the left eye, still in zone 2 and stage 2. He was improving the right eye. After 10 days, it was both eyes, zone 3 with the stage 1. So he was improved. Observation after 10 days, he was seen in, he was examined in OR under anesthesia. Fundus examination was done. Zone 3 with stage 1, both eyes. At the same day, he received laser and direct ophthalmoscope to both eyes with fundus photos by RITCAM. So here, you can see, it's approximately reaching the temporal area to zone 3. This is the nasal area here. You see the plus is resolved, and this is the fundus fluorescein for both eyes. So the final visit, he was stable after laser, but we don't have actually laser photos here after treatment. So plan was to follow up with the pediatric. So this is actually the presentation from Dr. Dahmish for basic science course. I couldn't find any better than this resource because I looked to 3 resources. It was the actually the best. I added some slides and some notes on it. So vascularization normally begins in the 16 week of gestation from hyaloid vessels at optic nerve, then extends to periphery, reach the nasal periphery at 32 weeks and the temporal periphery at 42 weeks. ROP is proliferation of vasculature of retina due to hypoxia or decreased oxygenation of or avascular retina. So new vessels will grow to try to compensate. Risk factor, the most important one is low birth weight, low gestational age, supplemental oxygen, and others. The incidence of ROP, premature infants, is inversely proportional to the birth weight. The less weight, the more aggressive and the aggressive ROP. ROP in 1995 account for 10% of cases of blindness in children in schools and South Africa. Annually, 500 to 700 children become blind because of ROP. The indication of screening of preterm babies, the age will be less than 31 weeks, and the weight will be less than 1.5 kilograms. When to screen? If the gestational age for any newborn is 23 to 24, the screening will be from 3 to 4 weeks. If the patient age 25 to 28 weeks, will be from 4 to 5. If more than 29, it will be upon discharge from a neonatal ICU. This is the procedure of screening, using usually 28 or 25 diopter lens, and trying to localize first to see if there is plus or not, localize which zone. So by putting a lens, usually 28 lens, the edge of the lens will be on the disc by any quadrant, usually temporal or nasal. You will see at the periphery, this is usually the zone 1. So putting the lens, the edge of the lens to the disc, at the temporal part, nasal part, sorry, this is the edge of the zone 1, and the reverse from temporal part here. So you will, by 28 lens, it will guide you localizing the zone. So the first study I would like to discuss is the international classification of ROP. This study provided the uniform nomenclature to describe ROP, which facilitated communication and conduct of multi-center clinical treatment trials. The result of this study, localization of disease, the zones, and also the clock hours, or the extent of the disease, the severity of disease by stages, then the presence or absence of blood disease. So this is a summary of this study, international classification of ROP regarding the zone. So zone 1, as we said, it's the area circle with radius of twice distance from optic nerve to the center of the fovea. So this distance from the disc to the fovea, it will be doubled. This is the zone 1. Zone 2, it's outside this zone 1 till the nasal periphery of the retina. Zone 3, it will be the remaining part of retina. Stages of the disease, it will be 5 stages. First one is thin demarcation line. It's only white or yellow-white line. Stage 2, it will be a ridge, elevated line. Stage 3, there will be a vascular proliferation. 4, there will be a retinal detachment. A will be subtotal without foveal involvement. And 4B will with foveal involvement. Stage 5, it will be total retinal detachment. And regarding plus disease, the plus, it will be engorgement and tortuosity of vessels. Pre-plus, it is the extent of disease between plus, which is present in this picture. So this is the stage 1. You see here the only demarcation line. Here stage 2, elevated ridge. Stage 3, you can see the fibrovascular elevation. Stage 4, this is stage 4, I think, B, because it's involving fovea. And this is total, which is stage 5, total retinal detachment. So this is the plus disease. So this is the standard picture of plus disease. Between normal and this picture, let's see, severe plus, this is what we call P plus. So additional features of plus disease, it will be iris vascular engorgement, poor pupillary dilation, and vitreous haze. Threshold disease, it is description of a disease that either in zone 1 or zone 2 with at least 5 continuous or 8 total clock hours of the disease with the presence of plus. This threshold disease has a 50% likelihood of progression to retinal detachment. The second review of this study, International Classification of ROP, has refined this, the diagnosis or criteria to be to include pre-plus disease and expand the understanding of aggressive posterior ROP. So this is the pre-plus, as we said. This is a picture of pre-plus. It's not severe plus disease, which is dilation, not that dilation and tortuous fizzles. So we have two definition, pre-plus and aggressive posterior, that has been described by this study. So what's aggressive posterior ROP? It is localized in zone 1, and the second one, prominence of plus disease. Third one, ill-defined nature of retinopathy. You cannot judge which stage. So what's the importance of aggressive posterior ROP? This rapidly progressing retinopathy has been referred previously as rush disease. Usually it does not progress through the classic stages 1 to 3. Eyes with aggressive posterior ROP should be promptly treated with laser. So this is a picture of aggressive posterior ROP. So aggressive plus disease, zone 1, and ill-defined age. So regarding the treatment of the ROP, we have early treatment of, actually first one is cryo ROP study, which has the first study to be done to include ablation of avascular retina in ROP patients. So the primary goal of cryo ROP study to resolve uncertainty about the value of peripheral retinal ablation treatment. Secondary goal of cryo ROP has been to determine the long-term outcome of eyes with severe ROP, both with and without ablation. It's possible that treatment of earlier stage may also have effective outcomes. That's when early treatment of ROP study comes. So the result of a cryo ROP study, 256 infants, 492 eyes tested, only 358 eyes had photograms. 49.3 reduction in the unfavorable outcomes rate at 3 months in treated eyes versus the untreated eyes about 21. At the 10-year outcome measurement, 44.4 of eyes had unfavorable visual outcomes, but only 27 showed unfavorable anatomical outcomes in the intervention group. So the second study, it was early treatment of ROP. The purpose of this study was to test whether early treatment will be more beneficial applied to pre-threshold eyes. So we have to So we have threshold disease as we prescribed with the clock hours, and we have pre-threshold. This is what was, this is the early treatment of ROP. The early group was intervened in that study. So the type 1 ROP, which has to be treated, the criteria will be in zone 1, stage ROP with a plus disease, any stage with plus, or stage 3 without plus disease. The second one, it will be in zone 2, stage 2 or 3 with plus disease. This is the group need to be treated. And the type 2 ROP, zone 1, stage 1 or 2 with no plus disease, or zone 2, stage 3 with no plus disease. So the second group will be followed until they will progress to type 1 and they will be treated or they regress. So the early treatment study was to treat those patients, pre-threshold patient. The result of this study, reduction in unfavorable visual outcomes with early treatment, 19 to 14. Reduction in unfavorable structural outcomes from 15 to 9 in non-treated eyes. Further analysis supported retinal ablation therapy for eyes with type 1 ROP and wait and watch approach for type 2 ROP. Conclusion, early treatment of high-risk pre-threshold ROP significantly reduced unfavorable outcomes in both primary and secondary measures. This is the recommendation follow-up intervals with when plus disease is absent. In stage 3, with laser treatment, stage 2 and stage 1. Usually in zone 1, it will be within a week or 2 weeks. Zone 2 within 2 weeks. Zone 3, 2 to 3 weeks. So regarding the treatment of ROP, any eyes meeting the criteria for type 1 ROP should be considered for peripheral retinal ablation treatment, whereas type 2 ROPs will be monitored, as we said, until they progress to type 1 will be treated or regress. Once laser treatment needed, treatment should be within 72 hours. Entire avascular retina should be ablated with laser, but in cases of zone 1, it's better to avoid the fovea. Complication of treatment, intense post-op inflammation, cataract, glaucoma, hyphemia, vitreous hemorrhage, and phthisis bulbi. Topical cycloplegic and steroid, it's indicated after the laser treatment. This is schematic representation of how laser treatment will be to the avascular retina. It's a bit confluent and it does not overlap, and it is cryotherapy, yes. Sorry. Regarding intravitreal anti-VEGF agents, we have a study here which is BEAT ROP. Bevacizumab eliminates the angiogenic threat of retinopathy of prematurity. The cooperative group. Bevacizumab monotherapy for zone 1 or zone 2 posterior stage 3 ROP with plus disease. Compared with conventional laser therapy, a statistically significant treatment benefit from bevacizumab was demonstrated for zone 1 ROP, where zone 2 disease had a similar outcome with either treatment. Recurrence occurred significantly later with bevacizumab than with laser therapy, therefore prolonged close follow-up is essential. Safety of anti-VEGF for treatment of ROP has use of Avastin in eyes previously treated with laser and is not recommended. So what's the sequelae of ROP? We have certain complication of ROP, macular heterotropia, which is dragging, myopia. It is strongly associated with the severity of ROP, anisometropia, amblyopia, glaucoma, phthisis bulbi, and strabismus. Intravitreal injection of anti-VEGF have a promising result, especially in zone 1 disease, as in our case today. So vitrectomy and buccal eyes and undergoing surgical intervention at stage 4A, which is retinal detachment without fovea involvement, rather than at later stages, 4B or 5, have more favorable outcomes. Lens-sparing vitrectomy for stage 4A ROP may reduce the progression to stage 4B and 5. For eyes with stage 5 disease, vitrectomy has been successfully reattaching the retina in approximately 30% of eyes. Only 25 of retinas in eyes with initial partial or total reattachment after surgery remained fully attached median of 5 years. Only 10% eventually have ambulatory vision. Recently, we have a new technology that help areas where there will be underserved by ROP trained, which called computer-assisted analysis. It can assess the plus disease and can give you initial diagnosis to help those specialists. Thank you.
السلام عليكم. إن شاء الله ما نمتوا هذا آخر presentation وتروحون البيت إن شاء الله. Today I will be talking about fever, familial exudative retinopathy, under the supervision of Dr. Abdurrahman Al-Faran. Thanks for him for providing me some of the literature I will present today. So my case is a newborn, 5 months old male, corrected age 3 months. He is preterm of 32 weeks, referred from Medina for neurology consultation as a primary team and for ophthalmology consultation. The active issue where the patient was known case of hydrocephalus for workup and management, and there was history of retinal hemorrhage. For a positive history, he was birth weight of 1.4 kg, history of mechanical ventilation, history of an ICU hospitalization for intraventricular hemorrhage of grade 3, history of DVT of the lower limbs, review of other systemic symptoms were negative, ophthalmology review were negative, including family history of ophthalmologic problems. Systemic examination is within normal. Ocular examination, visual acuity was no response in the right eye and blinks to light in the left eye. Intraocular pressure within normal, pupil within normal, anterior segment within normal. Reflex was dim reflex in the right eye and good reflex in the left eye. Fundus examination in the right eye showed total retinal detachment. In the left eye, healthy disc, flat retina and peripheral avascularization. Sorry, it's not vascularization. So what is your impression after this? It will be fever or not fever? Impression after the history and examination. The impression goes with fever or against fever? Actually, it does not go with fever. فعشان presentation حقي عن fever مو معناه أن خلاص it's fever from the beginning, all right? Impression is ROB, but it is asymmetrical. It's atypical ROB because in ROB patients, the patient most likely, if they present with the stages, it will be comparable stages between both eyes. But this patient, he was total detachment in one eye, and the other eye was only peripheral avascularization. So impression was ROB asymmetrical for workup. The plan was examination under anesthesia and FFA. The preoperative diagnosis was ROB. Examination finding was the same. Those were the pictures taken. FFA was done. In this picture, we can see in the periphery, we can see peripheral avascularization. As the phase goes more, we can notice some leakage that it will not show in the only fundus examination. So postoperative diagnosis, in the right eye it was stage 5 fever, in the left eye it was stage 2. FFA finding, it was avascular area with leakage in the superior temporal retina. Management, it was surgical repair with guarded diagnosis for the right eye, but the family refused. And in the left eye it was LIO. Patient was followed up and seen by pediatric ophthalmology. No need for glasses and to keep follow up with retina. Was seen again with retina, and patient underwent FFA after 3 months from the first intervention. It was no active, no progression, no leakage in the FFA. Management was to keep monitoring and to be seen after 6 months with FFA again. So today I will be discussing certain objectives, genetics, pathogenesis, how to approach patients, findings and stages, some major differences between ROB and fever, and management options. So speaking about how fever started, it was described by Chris Wick and Shibbins in 1969. It was started as only a clinical feature, was based on the peripheral retinal avascular changes, including retinal neovascularization, macular dragging, subretinal exudation, but it was not staged. It was only findings in the peripheral avascular retina with some complications. In 1976, Kani and Oliver, they applied the use of FFA in fever. In 1998, Pendergast and Trees described a classification scheme, which was updated recently in 2011 by Tosher and Ranchod. The avascular retina is present from birth and may progress long-term complication even in adulthood. Genetics, the family history is reported only in 20 to 40%. The literature varies. Some they say 20, some they say 40, and some literature they say in Dutch families it may reach up to 60%. The expressivity of the disease, it may vary within the same family, within the same patient, between both eyes. As we saw in our patient, one eye was stage 5 and the other eye was stage 2. It is inherited in 3 patterns: autosomal dominant, autosomal recessive, and X-linked recessive. Those are the common genes. The FSD and LRP in as autosomal dominant, and they are the most common. Also, again, fever can be present as only isolated ocular disease and can be presented as syndromatic disease, which is very rare. It can reach up to 1 in 2 million because the disease itself, it's rare. So also in about 50 cases of the diseases, the mutation of fever is not known. So as I described earlier, it can be non-syndromatic and syndromatic. One of the examples of if it is syndromatic, if it is associated with LRB5, the patient may have osteoporosis pseudoglioma. The patient may have, they are more prone to fractures along with the ocular finding of fever. And it's also another disease, they may have mental retardation and deafness along with the ocular finding. So for the genetics, it's located in the chromosome 11. LRB, yes. Yeah, but they're sharing the same genetics. Mm. Mm. Thank you. So we always cross by or pass by many genetics, but we don't know what's the role of this gene to cause the disease. So I will take one example. For example, the LRB or the LDL receptor related protein 5, it is located in the surface of the cell, and it acts as a receptor to receive the signals. So if it is mutated, it will no longer be functioning and it will no longer be getting the signals. So no longer vascularization and angiogenesis will happen. So regarding clinical features and diagnosis, you should ask about general history of the patient, positive family history of ophthalmic diseases, fundus examination, lack of peripheral retinal vascular development. You should ask about history of prematurity in preterm born. You should look for variable degrees of vitreoretinal traction, subretinal exudation, retinal neovascularization, and wide field fluorescein angiography is a must in favor. So what does the literature say? Those are 4 studies. I will mention some of the findings they mentioned. The first one, this one is done by Tusher and Ranchud started in 1987 or 1984 until 1998, until 2009, sorry, and it was published in 2011. The study included 145 patients with total of 273 eyes. It showed epidemiological-wise, it shows male predominance. The mean age was, the mean birth weight, it was 2.7 kg. The gestational age, the mean age, it was 37.8. Although we can see very early preterm neonates, And the age of presentation, it was the mean age. It was almost 5 to 6 years. What was the referring diagnosis in this study? It was most commonly fever, but it was also referred as RDs, persistent fetal vasculature syndrome, ROBs, retinal folds were the most common. But we can see also up to toxocariasis, it was referred as a differential diagnosis for a case. This is the new staging system done. It is 5 stages. First, it was the avascular periphery. Second, retinal neovascularization. Third, extramacular retinal detachment. Fourth, macular involvement retinal detachment, but it's subtotal. And fifth, it is total retinal detachment. So this is the stage 1, as you can see. It was Gilmore. Stage 1 here, we can see the peripheral avascularization. Stage 2, we can see leakage from the neovascularization. Stage 3, sorry for the quality, it's extramacular traction. Stage 4, macular traction, and we can see some of the exudation. So this is stage 4 B, and 5 total detachment. Also very common to have is the retinal folds in fever. It has different looks. But most likely or most commonly it will be on the temporal or inferior temporal area. It was present in 28% of patients. This is also another study. It reviews multiple studies, including the previous one. We can see the peripheral avascularity, it was in 97%. Some studies it was 79, and some studies it was 100. Although it is very specific to fever. We can take example of neovascularization. It was 12% in Ranchid, here 11, and some studies 27. So it varies because the disease, or most of the studies, is retrospective, is not prospective studies. So most of the patients are referred. It's maybe even with stage 4 or stage 5. So this is a schedule I passed by our crest while I was researching, comparing ROB to fever. The first one, it was absent in fever. It's not absent. It is less likely, but it may happen to have a premature patient with fever. Family history of disease may be present in fever. Birth weight often normal, although in our case it was not. History of supplemental oxygen most likely absent, but in our case it was not. Exudate is more likely goes with fever. Course of the disease is unpredictable with fever. On the other hand, ROB is more predictable, and it stabilizes after a period of time. And reactivation in fever is very common. It's not very common, but it may happen, sorry. And regarding management, generally, relatives of the patient should be screened. Lifelong monitoring is required. The primary treatment is laser. Vitrectomy, we do it for retinal detachment. Anti-VEGF can be useful. So for stage 1 fever, requires no treatment, but regular follow-up. And the peripheral avascular area should be ablated with laser in case of neovascularization, demonstrated leakage in FA, like we saw in the case. Laser, it was done in some patient in stage 4, and also it was successful treatment. Although stage 4, it is there is traction, so we go likely to vitrectomy or scalar buckling in some cases. In patient with RD, surgical intervention should be considered either scalar buckle or PBV. In single study, intravitreal injection of agents of vegetatinib or Avastin, and both of them showed regression of the disease. This is another study it was done also by Pendergast and Scott. They mentioned the management or the options of treatment, whether it was laser or surgical in patients, and they followed them up over a mean follow-up of 35 months. The outcome with laser, most of it was reasonable because the stages were early, although some patients we can see stage 4 and they were managed with laser and with no subsequent surgeries. The visual acuity, it was done by Snellen charts. In children, it was done with HO2V or E charts. Regarding surgical options, also they mentioned whether the macular status after the procedure and whether the patient needs a subsequent procedure. This is the final results of the treatment. We can see patient with 20 to over 20 to 20 over 100, good percentage, and it goes on until NLB vision. Most likely the patient with stage 4 and 5 who underwent or undergo surgical intervention, they don't do well because they may have recurrent detachment and they may need further surgery. So, in summary, stage 1 we monitor, stage 2 it's laser, but we can give anti-VEGF. Stage 3, if it is partial or extramacular, we can give we can do sclerobuckle, or we can go for vitrectomy. Also, plasmin has been used in in the previous study to relieve of some of the traction. So, in conclusion, fever is inherited in many patterns. Peripheral zone of avascular retina is the sign of the disease. Fibrovascular changes and traction may happen. It is recurring and unpredictable course of the disease. You have to rule out other differential diagnosis. Primary treatment is laser, and you have to follow up patient for life. Those are my references. Thank you, everyone. السلام ورحمة